My name is Larry Schwartz, and I chair the Division of Rheumatology, Allergy, and Immunology, and I welcome you all to Department of Internal Medicine Grand Rounds today, and today is the Thomas Lecture. Just briefly, Charles and Evelyn Thomas, the Thomases, are grateful patients of our rheumatology faculty, and they showed that gratefulness by donating funds to our division that established an endowed chair, professorship, fellowship, and research fund, and which we're forever grateful for them to have done that. Today's speaker, who I know you're going to enjoy, is one of our own, Brant Ward, who came to us from Southwestern in Texas after completing the MD PhD program there, his PhD being in immunology. He joined our faculty in 2014 after completing a research track residency in internal medicine and then fellowship in allergy immunology. And since that time, he has put Virginia Commonwealth University on the map as a site for primary immune deficiency. He spearheaded the effort in our state of Virginia for newborn screening for severe combined immune deficiency to be approved. And he also established us as a referral center, both at the Jeffrey Modell Center and the National Immune Deficiency Foundation for primary immune deficiency patients. So today, Brant is going to talk to us about the surprising truth about adults with immune deficiency disorders, with the explanation that yes, you will see them in your practice. So without further ado, I'll turn things over to Brant.
Great. Well, it's nice to see everyone today. Thank you very much for asking me to give the Thomas Lecture today. I'm going to go ahead and share my slides and we'll get started. So like Dr. Schwartz mentioned, yes, the surprising truth is, I think, for most people, that you will see these patients in your practice. So before we get started, I do have a couple of disclosures. I did receive some funds for an investigator-initiated research grant, a research project, and I have served on the Speakers Bureau for Takeda Pharmaceuticals, neither of which are going to directly impact what we're talking about today. All right, so as far as what I think we should try to accomplish today, I'm hoping to start off and teach everyone a little bit about the epidemiology of primary immunodeficiency disorders, particularly the ones that we see in adults. Hopefully from this, we'll be able to kind of understand and discuss why recognizing these patients might be important and how this can actually improve outcomes. And then we'll talk about some ways for everyone to go out and to help be able to identify these patients in the practices, on the rounds, in your clinics, et cetera, and hopefully get these patients identified and into the right diagnostic and treatment channels. All righty. So I'd like to start off with a little case here. These are real patients. I've tweaked a few of the little details to kind of condense things and make it kind of flow a little bit better, but these are all patients that we have seen in our practice. So starting off with a 26-year-old who presents to the clinic for a sick visit. Has been complaining of a wet cough. Symptoms began about 2 weeks ago. Consist of sinus pressure and headaches, some congestion, mildly elevated temperatures, some postnasal drainage, and she is coughing up some greenish yellow sputum. So this started about 2 to 3 weeks after she completed a course of doxycycline for similar symptoms. So she feels like the antibiotic she was on before didn't quite kick the infection very well. In terms of past medical history, she had several courses of antibiotics for sinus infections and bronchitis each year for the past 3 years. She was diagnosed with pneumonia in 2018 and again in 2020. These are both treated as outpatients. She had shingles, in 2011 as a teenager. He's had some mild eczema since childhood, which has really improved and has not been an issue as an adult. No significant surgeries. Drinks a couple of drinks every week, but otherwise no tobacco and no other illicit drugs. On exam, her temperature is mildly elevated, but otherwise vital signs are pretty normal. She does have some tenderness over her maxillary sinuses bilaterally, does have some drainage that you can see in the posterior oropharynx. A few enlarged and tender lymph nodes bilaterally. On lung exam, there are some few kind of scattered early inspiratory crackles, but these clear after she gives a couple of good coughs. And her cardiac exam is pretty normal. Alrighty. So now this is I think a situation that a lot of people have seen come through their clinic. Certainly in primary care clinics, this is a really common occurrence. And there, as we'll talk about here in a little bit, there's some warning signs here that I think this is more than just a routine sick visit. As it turns out, this patient was seen by a pulmonologist, was referred to pulmonology for the question of pneumonia. They decided to get a CT scan. And so here is her CT scan. And I think everyone will appreciate this is not a normal CT scan of the lungs. So a couple of features that make it a little bit unique. So this looks like an interstitial pattern, but it's not a usual interstitial pneumonitis type pattern. There's no honeycombing, but there are a few features that stand out. One is the bronchiectasis here. You can see it's a kind of cylindrical bronchiectasis. There's some scattered nodular opacities. There's also some scattered ground glass opacities. And there's some nodular opacities that have a halo of ground glass around them. So this pattern is not terribly specific, but seen together, and especially with the history, was very concerning. So she was referred over to us, and as you might imagine from the title of the talk, her immunoglobulins were exceedingly low. Her titers to some of the routine vaccines, tetanus, diphtheria, and pneumonia, were essentially non-existent. And even after vaccinating her and seeing the response afterwards, there was really no response to be seen. And on flow cytometry, we found that she had very low naive T cells, which is really a sign of dysregulated immunity. And so this patient was diagnosed with common variable immunodeficiency. And so I think this kind of illustrates how some of these routine visits really can be something more that we should kind of dive into. So without further ado, I wanted to talk about a couple of myths about primary immunodeficiency disorders to start off with. First one that I hear a lot with residents and students coming through it is, aren't they pretty rare, or some variation of that, like I'm never going to see those in my practice, or someone else is bound to see them because they'll get diagnosed and sent somewhere else. So putting it into perspective, this is some data based on some population estimates done a few years ago, but still I think it's pretty telling. So total, all of the immune disorders kind of put together, they have about the same incidence as multiple sclerosis. It's something that we talk about a lot in medical school. I think most people have it kind of in the front of their mind when you see patients with neurological symptoms. Now, one of the caveats to this 83 per 100,000 is that it does include patients with selective IgA deficiency. Now, IgA deficiency is pretty common. It can be seen in up to 1 in 250 in certain populations of European descent. Kind of total in the US, kind of a lowball estimate of its prevalence is about 1 in 4,500. Now, most people with IgA deficiency are identified serendipitously. They don't have recurrent infections, and they're identified when people get IgA levels for celiac disease, or they're sometimes picked up in blood bank screening programs, et cetera. So even if you take out those relatively clinically insignificant IJ deficiencies, primary immunodeficiency is still more common than lupus. So I want everyone to think about that. How many times have you ordered an ANA to screen for lupus? And then think about how many times did you order antibody levels to screen for primary immunodeficiency? So I think there's a disconnect there, and I'm hoping we can address that a little bit. So we know that it's been estimated that worldwide, a lot of people are out there that haven't been diagnosed with primary immunodeficiency just yet, up to 70 to 90% of people worldwide. When you translate this into developed countries, that suggests that half of the people living here in the United States may be undiagnosed, and we have only kind of touched the surface of the patients and started them on proper treatment. There's a lot of people out there that are living with primary immunodeficiency that we're really missing. Okay, so who sees these patients? I think it's important to realize that it's medicine providers and family practice providers, primary care, that really see a lot of these patients. So this was a survey, a nationwide survey conducted by the Immune Deficiency Foundation. It's a patient advocacy group for primary immunodeficiency. And they asked these patients, who is the doctor that you see most often for your care? And as you can see, the primary care, family practice, and internists were by far the biggest categories here as well. But other medicine subspecialties also were being seen by these patients. So pulmonology, ID, hematology, GI. Moreover, if you ask them what other physicians they'd seen in a year, even if it wasn't the most common visit, but any physician they'd seen in the past year, there's a whole lot of medicine subspecialists on this list here that you can see. So hematology was a big one, pulmonology, allergy, cardiology, endocrinology, infectious disease, GI, rheumatology. So a lot of these patients are coming through our clinics, and I think it's the burden's on us now to find these patients and diagnose them. Okay. So another myth is I hear that well, it starts at birth, right? So those patients are already be identified, right? Or variants of that. They only develop in young kids, or they should only be suspected if someone's been sickly their whole life. Well, if you look at worldwide prevalence of primary immunodeficiency disease, you see that more than 50% of the people living with primary immunodeficiency are adults. Looking at developed countries like Europe, North America, Australia, you see that well over half of them are as adults. Here in the US, it's estimated to be about 65% of patients with primary immunodeficiency are adults. Now, one might argue that maybe this is from kids that are being diagnosed and then just surviving longer into adulthood. That's not exactly the case. When looking at incidence, so this is new diagnoses of primary immunodeficiency, you'll see here on the right side of the screen that, again, over half of all new diagnoses of immune disorders happen as adults. So these are patients that are being seen by internists, seen by hematologists, and that are being diagnosed because symptoms started as an adult. Okay. One of the reasons I think this myth about kids being where immunodeficiencies start comes from some of the things that we learn about in medical school. So we get taught about chronic granulomatous disease here in Brown. You get taught about severe combined immune deficiency or bubble boy syndrome in medical school. So here, and other disorders like some syndromes that have associated immune deficiencies, DeGeorge syndrome, Wiscott-Aldrich syndrome. These do present in infancy, usually early in childhood. But you can see from this table here that as people get older, it's really antibody deficiencies here in orange that really predominate. And they don't have some quite the same striking, invasive, weird infections that some of the combined immune deficiencies or granulocyte deficiencies do. And I think that's a lot of why they get missed and why a lot of people focus on that history of it starting very early in childhood. Okay, so how can we use this information to help us improve outcomes in these patients? So I put up this slide. This is David Vetter. This was the original bubble boy. And even though this is severe combined immune deficiency, this is not something we see as adults, but I think it highlights that we've come a long way and we can improve care for these patients. We don't put people in bubbles anymore, and we can significantly improve their quality of life. And that includes patients that present as adults. So one of the things that's kind of striking about when people get diagnosed is this delay that happens between the onset of symptoms and when they finally get their diagnosis. For a lot of people, it may be 1 or 2 years, a handful of years, but for a lot of adults, it ends up being many years, even decades after they started getting infections. By the time they first start to get someone thinking, this is not right, we need to get them checked out. So during this time, there's a significant amount of lost productivity. So this is, again, for population surveys, we know that 75% or so of patients with primary immune disorders will miss at least 1 week to a month or more of time off of work or school. This translates to a lot of missed earnings. It translates into a lot of extra cost to the health system as well. And I didn't put it into the presentation, but this also translates into savings to the health system and stuff once treatment has been started. In terms of their own perceived health status, many more people felt their health to be poor or very poor before they were diagnosed. Once they got the diagnosis, got on proper treatment, the majority of patients list their health as good or very good, which is a pretty incredible feat that we can actually improve their quality of life quite that much. We also know that with that delay comes, unfortunately, some permanent loss of function. So the longer people go before they've actually been diagnosed, the more and more permanent functional impairments that they acquire. Some cases 1 or 2, some cases 3, 4, 5 or more permanent changes in their health status that may not be gotten back. These are things like lung disease. Lung disease is really a very common issue with people with immune disorders. And so that's a big one. Bronchiectasis, scarring, things that may not necessarily get better. We also see loss of digestive function. This is a big issue for people, and this includes liver disease and things like that, which we can't really dial back as well. Of course, hearing loss can be a big one for people that get recurrent ear infections and conductive hearing loss. Neurological losses can happen as well. This includes like neuropathies. It can include certain infections in the CNS, etc. Mobility can be lost quite a bit, even vision. So a lot of these things are very impactful to the patients and dramatically limit their function afterwards. Okay. So I want to use one particular disorder. I highlighted it, or I kind of mentioned it before. It's common variable immunodeficiency, or CVID, to kind of illustrate some of these sequelae that happen in these patients. So if you look at this cohort here, only about a third of these patients had only infections as their main complaint. 2/3 of them or more had other issues that came up. Chronic lung disease, like I mentioned, was a big one. Autoimmunity is a significant burden for them, with cytopenias like ITP being a big one. GI disease is also a really hard one on patients. People can live with a little low platelets, but when you have diarrhea every single day, 10 times a day, it's hard. It makes it really hard. And liver disease can be a significant issue because unfortunately we can't do as much to turn back once the liver disease has started. And this translates into poor outcomes for these patients. So as you can see here, patients with whom only get infections, they do pretty well. We can start them on treatment and they do great. The other patients have a harder time and their survival dramatically drops off. Some of these things we can do, we can prevent them. We can help to stop some of these things before they start if we get these patients diagnosed early enough. And in terms of what they actually die from, you'll notice here that it's not infections. It's lung failure. Lung disease, like I mentioned, is a really big problem. There is an increased risk for lymphoma in these patients, as well as other cancers, stomach cancer, lung cancer, skin cancer, etc. And then liver disease can be another big burden. So it's all these things that if we can diagnose them early, get them on treatment, we may be able to delay or stop. And we also may be able to know how to screen for them earlier to catch them early in the cases of lymphomas and cancers. Okay. So what do we do for treatment? Well, IVIG or immunoglobulin infusions has been really a game changer. We started using these infusions a long time ago, 50, 60, 70 years ago. And we know that they improve infections quite a significant amount. So this is period prevalence of pneumonia in CVID patients. And I think it's pretty easy, as even for the most nearsighted person here, to see the difference between these two bars. It's a big change, and the incidence of serious bacterial infections is dramatically reduced after starting immunoglobulin therapy. But even just beyond infections, we know that immunoglobulins have a beneficial effect on other aspects of the disease. So bronchiectasis is an example here. A lot of the scarring with bronchiectasis is permanent, but there are some features that can be reversed or lessen the impact of, and we see that there's a difference. It's small, but it's there. Certainly types of inflammation in the lungs can be improved, like opacities, nodular opacities, ground glass opacities that are due to inflammation and infection can be improved after starting immunoglobulin. As one would expect, fibrotic changes don't seem to change much. And this is, I think, unexpected, expected by most people. So, but still, overall, the symptoms in this case, high-res CT scores as a surrogate for disease activity can dramatically improve after IVIG. Okay. Now, I wanted to take a few minutes to talk about a couple of specific cases where targeted therapies may be helpful as well, too. So immune disorders, I think, are one of the fields where personalized medicine and molecular medicine, I think, is really the benefits of this have really been borne out. So talking about these two, CTLA-4 is a checkpoint on immune cell function. It's a protein that's on T cells that blocks stimulation and co-stimulation and activation of T cells. And so it serves as a checkpoint for T cell activation. LRBA is another protein in the cytoplasm of T cells that helps to stabilize this CTLA on the surface of the T cells. Now, using genetic testing, we've identified a significant chunk of patients with CVID, for example, that have monogenic changes in genes like these two. And so we know that, if we can identify these patients, they present very much like CVID, low antibodies, recurrent sinopulmonary infections, poor responses to vaccination. And in the case of these particular disorders, they do have significant autoimmune disease. I think anyone who has used a checkpoint inhibitor or seen patients that have been on checkpoint inhibitors will realize that they can have quite significant autoimmune features that come as a result of using them. And these disorders are actually like the natural version of that. So using, I think, CTLA-4 inhibitor is a medicine called Yervoy. It's used for certain cancers, but the end result of using it is they have a high risk for cytopenias, for autoimmune enteritis, autoimmune liver disease, autoimmune lung disease, rashes that are pretty bad, even CNS inflammation from autoimmunity. And we see that all in these patients here. So Betacept is this wonder drug for these patients. Betacept is a recombinant form of CTLA-4 linked to the Fc portion of an immunoglobulin molecule. When you give this, what it does is the Betacept molecule binds to the co-stimulatory molecules on APCs and prevents the T cells from getting activated. So The normal kind of inhibitor on the T cells themselves, if it's missing, we kind of give it the extra, we take its place with the exogenous protein. And as you can see here, lung disease in this patient with CTLA-4 deficiency was dramatically improved. So going from all these different inflammatory nodules to essentially nothing in the lungs. Some ground glass and mosaic attenuation here to nothing. A lot of nodular and tree and bud opacities to nothing. In terms of spirometry, we've seen 100% improvement in FEC, FEV1, and even diffusion capacity in these patients. So it can work really well. And other kind of autoimmune features, you can see here, these patients had developed splenomegaly, ITP, autoimmune hemolytic anemia, chronic diarrhea, uveitis, lung disease, dyspnea. And after starting Betacept, you see all of those things have melted away. So it can be a pretty dramatic improvement in these patients' lives. Another example I'm going to mention here briefly is something we call activated PI3 kinase delta syndrome. PI3 kinase delta is, if you guys can remember way back to biochemistry, it's one of these proteins that takes the signal from the cell surface and transmits it down to transcription factors that then affect gene function. And in immune cells, normally this protein is in an auto-inhibited state. And then only gets turned on when the T cell receptor is activated, for example. Certain genetic defects will lead to constitutive activation of this protein. And this causes constitutive activation of immune cells, which, as you can imagine, is not always a good thing. So these also present with a CVID-like phenotype. They have lowish to normalish kind of Ig levels. They may have elevated IgM too, as a clue, but they get recurrent sinopulmonary infections. They have poor responses to vaccines. They may have persistent herpes virus infections with things like CMV and EBV. They develop autoimmune cytopenias. They can get lymphoproliferation and lymphoma. And there's even this interesting predilection for them to get sclerosing cholangitis. Just a little bit, it's very specific for this disorder, as it turns out. But there's this small molecule inhibitor of PI3 kinase called Linealisib, which was developed originally to treat certain types of malignancies. But when used for patients with PDS, it can dramatically improve their lymphoproliferation, as we see here. Spleen volumes have about halved in just about 3 weeks or 3 months. Lymphoproliferation in the lymph nodes, you can see here the diameter of the lymph nodes has about halved. So it can dramatically affect lymphoproliferation in these disorders. And we also see improvement in autoimmunity. Here in this case, thrombocytopenia has improved in these patients. So again, I think we have the tools to be able to zoom in and laser target these pathways and can restore immune function with little or hopefully no extra side effects or off-target effects in many cases. Okay. So I put up a few other examples of some targeted therapies in immune disorders here. There's an ever-growing list of them as we know more and more about the genes that are associated with primary immunodeficiency. And these are ones that we do see in clinic. So I don't want you to take this as to being something esoteric that is so rare. But I've seen a number of these patients here, and we have patients on ruxolitinib for STAT1, sirolimus for IPEX. These are all things that we actually can find and can see and can help these patients. Okay. All right, so finally, I wanted to switch gears again and talk about how we can go forward, go back to clinic, go back to the wards and recognize these patients. All right, so this little guy here, this is a space monkey. This is one of the monkeys that was launched into orbit back in the 1960s. It has nothing to do with immunodeficiency, but appeared when I typed in immunodeficiency into Google. So it's pretty clear that even Google has some trouble recognizing immunodeficiency. So I think that we can hopefully improve that a little bit. All right, so like I mentioned before, antibody deficiencies are by far the most common thing that we see in adults, especially common variable immunodeficiency. These disorders typically present with sinopulmonary infections. Now, sinopulmonary infections by themselves, otitis media, sinusitis, CAP, these are not things that are that uncommon. It's the same players as well too. It's strep pneumo, it's strep pyogenes, moraxella, Haemophilus influenza, even sometimes Pseudomonas. So it's the same things that we see in quote unquote routine sinus infections. The trick is to figure out which of these infections are actually just routine and which ones are a little bit more concerning. Okay. Now, there are some other cases of immune disorders that will present with invasive recurrent abscesses, fungal infections. We had a lady who presented with a very bad MAC osteomyelitis. Those things are unusual enough that I think a lot of people will pick them out. It's really these sinopulmonary infections that I think are the things that we should be focusing on. Okay. So again, common variable immunodeficiencies, the most common clinically significant immune deficiency that I mentioned. We've gone over this. It's characterized by low IgG, low IgA, and or IgM. And they typically have a poor response to vaccines, especially polysaccharide vaccines like pneumococcal vaccine, the PPSV23. So they all, or nearly all, have sinopulmonary infections as a hallmark. But we talked about some other features. They can have norovirus. They can have other GI infections as well too, that lead to chronic diarrhea, etc. So taking some of these features that we're talking about right here, a group from the Jeffrey Modell Foundation, another large patient advocacy group that was formed a number of years ago, have developed these warning signs for primary immunodeficiency. There's 10 of them here. I don't think you necessarily need to memorize them, but just remember you can always Google warning signs of immune deficiency, and they'll pop up in your search, and you can go through these. Some of these, like the recurrent need for intravenous antibiotics to clear infections, recurrent deep abscesses, family history, persistent thrush or fungal infections. I think a lot of people would pick up on these, but there's some that are really, I think, missed a lot by most providers. And that includes these up here. So adults don't typically get ear infections. Our eustachian tubes have grown since we were kids. And so adults, they drain well, they don't get ear infections that much. So if you see adults that are coming in with ear infections recurrently, that should be a warning sign that something could be up. Similarly with sinus infections, and this is a big one, I think it gets missed. So one of the caveats here is that people that have allergies, or if they have a significantly deviated septum or some other obvious cause for getting a recurrent sinusitis, those patients notwithstanding, most adults don't get recurrent sinusitis over and over again. And so if you see them coming in with 3, 4, 5 sinus infections a year, and true sinus infections, we've all seen patients that come in with a little stuffiness and say they want an antibiotic. But true sinus infections, 3 or more times or 2 more times a year, that should clue you in that maybe something else is going on. Same thing with pneumonias. Most adults don't get pneumonias without other features, other predisposing factors. Well, of course, having bad COPD, having bad heart failure, having kidney failure, these are things that will kind of predispose you to getting infections. But in the absence of that, if you see patients coming in with pneumonias, this is a couple times in a couple years, think about immune deficiency. Also, another one is chronic diarrhea with weight loss. This is another big one. I think it's pretty easy for a lot of us to assume that diarrhea is due to IBS and to kind of leave it at that. But this can be a big one and a cause for a lot of morbidity for patients. And then finally, infections with MAC or other kind of low virulence mycobacterium. So this is another one that happens. And now, not everybody that has MAC will have immune deficiency, but it's a bigger chunk of them than I think one might expect. Okay, so a couple of cases here to highlight some of this. I want to talk about 2 cases here side by side. One is a 5-year-old, one is a 50-year-old. Now, I know we don't typically see 5-year-olds, but I wanted to put it here kind of for comparison. So both of them present with boils. So a 2-centimeter boil with a little bit of drainage, all right? Now, the 5-year-old was diagnosed with Crohn's disease at age 6 months. Now, for the non-pediatricians in the group, 6 months is extremely early for someone to develop Crohn's disease. But he also had an Aspergillus empyema the year before. He had an older brother that died from serratia meningitis. All right, so that's pretty significant history, right? You're looking at the female here, has a ACL sprain during a skiing accident, had asthma as a kid, father with type 2 diabetes. Comparing these two, I think it's pretty clear, and most people would assume that, the kiddo is the one that has immune deficiency. And that's true. That would be much more likely. Now, this is not the most common case that we see. So contrast that with this, where we have a 5-year-old and a 50-year-old, both coming in with sinusitis, okay? They both have had 5 upper respiratory viral infections. The kid has, as a result of these, developed acute otitis media, which is, ear infection for the non-pediatricians. Has had ear infections 3 times in the past year. The adult has had 5 infections leading to sinusitis 3 times in the past year. Neither one has any history of allergies. The kiddo is in kindergarten 5 days a week. The mom works, or the female works at home as a financial analyst. So this is a little bit more tricky, I think, right? So this history alone doesn't sound like it's that significant, but in this case, yeah, it's this adult that is going to be much more likely to have a primary immunodeficiency than the kiddo is. Some of the features here, again, the bacterial sinusitis 3 times without a history of allergic rhinitis or other predisposing factor. He's working at home, so not exposed to a lot of infections and things like that as well too. So again, this is a common case that we see in resident clinic, and so I think we have to cue in on some of these patients and recognize them. Okay. So what do you do then when you have found someone who has an immune disorder? Well, this I think is a good chart. This is also from the Jeffrey Modell Foundation and kind of outlines how we go about working up immune disorders. There's kind of 4 basic steps, each with kind of more increasing complexity and kind of specificity. And in general, I think a lot of this is something that is best done by an allergist or an immunologist, but certainly I think anybody can kind of focus on the stage 1 right here. So it includes things like a history and physical. This is really important. If you notice that they have very tender sinuses all the time, if they have thrush in their mouth that didn't really talk about when they were talking about their sinusitis, things like that can be picked up. CBC and differential can be very helpful. Don't forget about the differential, because sometimes seeing that neutrophil count being very low or the lymphocyte count being very low or very high can give us a clue that something else is going on. And of course, don't forget about the immunoglobulin levels, IgG, M, and A, probably the most relevant to immune disorders, but don't forget about IgE as well too. If you see someone and their IgE is 200, that's a pretty good range for someone with allergies. And that might give you a clue that maybe that's more of a cause than primary immunodeficiency. Okay. I'll also add here for all adults, I think it's probably worthwhile checking HIV as well too. It's not as much of an issue recently. I think the epidemic of HIV is certainly in a different place than it was back in the 1980s and 90s. So, but it's still worth checking to make sure that we're not missing something that we could pick up and treat otherwise. And then referral to immunology, I think, is always a decent option. There are cases where people will have normal physicals, normal CBC, normal immunoglobulin levels, but still have a clinically significant immune disorder. So if your suspicion is still pretty high, you haven't found any other causes for that patient to have these recurrent infections, go ahead and send them over. They may be fine, maybe normal, or we might be able to find something else that could help out. Okay. So I'm going to end with one more case here, and I think we'll go through and talk about some of the features that hopefully people would would be able to pick out and just kind of as an illustration here. So this is also a real case of a patient of ours who's coming in to her GI clinic for follow-up of diarrhea. The 67-year-old was coming in for loose stools that had been thought for many years to be due to IBS. She complains today that her symptoms worsened about 2 months ago after receiving rituximab for rheumatoid arthritis, which she's had for a few years. She's still taking cholestyramine as prescribed, and that does seem to help a little bit. Doesn't make the diarrhea go away, but it helps. Because she still has some diarrhea, she occasionally takes loperamide, which also seems to help, but again, doesn't make it go away. She's tried a gluten-free diet. This didn't really seem to make any difference at all. Okay. So medical history is significant for RA, diagnosed back in 2009, followed by rheumatology. She's got sinusitis 4 or 5 times a year for 30 years, followed by ENT. Some normocytic anemia that's had a negative workup. She had C. diff colitis in 2011 as a result of some of the antibiotics for these sinus infections, but that's resolved. Surgical history is notable for, she had a partial colon resection due to C. diff, but that seems to have healed up and is doing okay. Had a hysterectomy in 1985, no tobacco or alcohol or other drugs. So even with these past couple, or these 2 slides here, I think there's a couple of things that are important to note. One, she's had diarrhea for a long time. It was thought to be due to IBS. Sure, you know, IBS happens. It's a very good thing. But then you start seeing this sinusitis 4 to 5 times a year for 30 years. That's a little bit too much. And now we're getting like two warning signs, 2 potential warning signs of immunodeficiency. Okay. So again, here's physical exam. It's largely normal. Vital signs are pretty normal. HNT is normal. Lungs are clear. Normal heart rate. The abdomen is non-tender, non-distended. Liver size is normal. No joint swelling. Her RA is pretty well controlled. So again, it seems pretty straightforward. So because the diarrhea was a little bit worse, they decided to go ahead and do colonoscopy and endoscopy for her. And from the duodenum, you can see here this patchy blunting of villi with increased epithelial lymphocytes. These are suggestive of celiac disease, but notably, I wrote in here plasma cells are absent. It seems like kind of a throwaway line, but I think it's notable in this case. So just by this, you know, you'd think, hey, is celiac disease what's contributing to this? But remember, she's already tried gluten-free diet. Didn't seem to help that much. And then from the colonoscopy, you see this. And I think a lot of people might miss it, but these little globules of stuff here and here and here, these are apoptotic bodies. And so they've described it as chronic active colitis with epithelial lymphocytes in cryptapoptosis. These findings are suggestive of GVHD, right? She doesn't have a history of bone marrow transplant or other transplant or immune-mediated colitis. All right, so that's atypical, and it could be missed. You know, if you didn't think twice about these little dots, usually the pathologists are pretty good about it, but you can see how one could pretty easily miss those 3 little dots right there. But because she had this weird finding, they did a CT scan of her belly, and look at this guy. Look what they found here. This is not a second liver. This is a giant spleen. And this was missed. This was missed in physical exams. I think 1, because people weren't really looking for it, and 2, maybe because it was so large, it was down into the left lower quadrant, and so they didn't feel the tip of it up high near the stomach. So she got referred over to us. Again, labs showed essentially 0 immunoglobulins. In all things, all immunoglobulins were low. We tested her for responses to vaccines, and her vaccine responses at baseline were non-existent and also non-existent after challenge. And when we did her lymphocyte flow cytometry, she had extremely low CD4 T cells as well as B cells. So with the low T cells, I'll say she was HIV negative as well too. So it's not due to HIV or other things, but she was diagnosed with common variable immunodeficiency. She does have a monogenic cause of it. She does have a pathogenic change in one of the genes associated with CVID. Unfortunately, her particular gene is not necessarily targeted or able to be targeted with specific therapy. But again, highlights that those monogenic causes are there. And so she's currently getting treatment. We're trying to see if we can rescue some of her bowel function, get her back on her feet. So just to conclude, primary immunodeficiency is more common than many providers realize. It does present most often as adults in our clinics, in internal medicine, in subspecialty clinics. And most providers will see these patients come through at some point. Hopefully you'll recognize it. And that's what the goal of this talk was, is to be able to pick out these patients and figure them out. We know that identifying those that have warning signs can hasten the diagnosis and hopefully improve that lag that we see. And as a result, lessen the amount of burden and functional impairments that they develop over time. And finally, that once we diagnose them, we can start treatment early, as well as including targeted therapies that can dramatically improve the outcomes for these patients. So with that, I'll just say thank you very much for having me again come and give the Thomas lecture. And with a few minutes left here, I'd be happy to answer any questions or answer any questions or comments. Thanks a lot.
So Brant, when you're working up primary immune deficiency in somebody with diarrhea, and you find that they have low immunoglobulin levels, some of that could be due to the diarrhea, and any consideration of how you decide whether it's the diarrhea or an underlying primary immune deficiency?
Yes, so that's a very good point. So with a lot of diarrhea, you can have protein loss. That's one of the reasons why a lot of people with diarrhea have low albumin and things like that. So one of the ways that we look for that is for looking for the presence of serum proteins in the stool. So we can check alpha-1 antitrypsin, for example, which is normally present in the serum. And if you see it at elevated levels in the stool, that can give you a clue that diarrhea may be causing some of the other serum proteins, like the immunoglobulins, to be lost as well too. Again, I think in this lady's case, probably some of that was due to diarrhea, her low antibodies, or some of it was due to diarrhea, but a significant portion of it, even with improvement in diarrhea, was due obviously to her CVID. Let's see. So I see a couple of questions here. I'll start with some in the chat, and some are in the Q&A as well too. So any recommendations for testing folks with multiple autoimmune disease, or is there an association there? And yes, there certainly is. So I think if you see somebody that has multiple autoimmune features, I think that's a good one to send for testing. The couple of disorders I mentioned there, like the CTLA-4 and the PI3 kinase, both present with lots of different autoimmunity. So I think if you see lupus, that's one thing. If you see lupus and you see autoimmune enteritis and you see other autoimmune diseases kind of all in one package, that's a suspicious thing. Now, certainly, I think the rheumatologist will tell you that lupus can have some other features as well, but multiple ones coming together, I think, is a good sign to send for workup. Let's see. All right, any comments about IVIG versus SubQ Ig? So yes, that's a very good question. I mentioned IVIG in the talk just because the best data, historical data, was with IVIG, but we actually prefer using SubQ as probably the best way to go. So with IVIG, you give it every month or so, and you see a pretty significant increase in levels all at once with a trailing off. Now, as they trail off and get towards that peak, we see sometimes people get infections. And when they're doing SubQ, it's given a little bit more frequently in smaller doses. So the levels tend to be a little bit more kind of a gentle wave rather than a peak and valley. And as such, their levels are more stable, they have less side effects, et cetera. So SubQ is definitely kind of the way to go. So we have, let's see, counseling patients for pre-procedures, for colonoscopy and invasive surgical procedures. So that's a very good one. And the one thing that's fortunate about these is most of the patients, like I mentioned, are antibody problems. They're going to have mainly encapsulated bacteria as their main issue. It's because antibodies are really needed to opsonize those encapsulated bacteria. So they don't tend to get staph. They don't tend to get perioperative infections. They don't tend to get translocation of GI pathogens during colonoscopy. So in general, thankfully, most of these patients are going to have about the same risk for getting procedures and stuff as other patients. Let's see. Any medications which can lead to immunodeficiency? Yeah, certainly this is a big one. As one might expect, immunosuppressives can lead to or kind of unmask immune deficiency. So some of the things that the rheumatologists will use, methotrexate, mycophenolate, these things for treating autoimmune diseases can unmask immune deficiency or can cause a secondary immune deficiency. Some of the ones we don't think about for secondary immunodeficiency include things like anticonvulsants, actually. So carbamazepine, Topamax, those can actually suppress antibody production and eventually lead to significant lowering, and they start to get infections and stuff like that. Other ones, let's see, those are probably the biggest ones. The immune suppressants and the anti-convulsants are probably the biggest ones. Let's see. So is it through AIR gene mutation that there's APS? AIR mutation ends up causing a disorder called APOSET. In our on our side of the fence, for endocrinologists, it causes autoimmune polyendocrinopathy syndromes, or APS. So yes, that is definitely one. And in particular, APS has the ability to cause autoantibodies to cytokines. So we see that when that happens, they can't make a good response to fungal infections, to viruses, et cetera. Excuse me. So they do have an increased risk for thrush is a big one. Notably, here with COVID, APS patients actually, they have autoantibodies to interferon, and that makes them extremely susceptible to severe issues with COVID. So if there's any APS patients that you guys have out there, please let us know. We'd like to make sure we address that and see if we can identify them and get that set up. Let's see. One question asked, do you recommend IVIG for hypogammaglobulinemia after rituximab or other depleting therapy like Campath? Or is there a clinical reason like recurrent infection or severe infection they may respond to IG? So typically, that's a good question. We do see that some people after rituximab do have delayed recovery of their B cells. For most people, it would take about 6 months to get their B cells to come back. But others, it may be a year, or 2 years, 5 years, or they may never get their B cells back. For those patients, if they have significant hypogammaglobulinemia, we do sometimes treat them with immunoglobulin infusions to help them kind of replace what is lost. Campath is another one that can be significant as well too. Campath has other cytopenias, T cell lymphopenia and NK cell lymphopenia as well. So that can cause other infections as well too. That's even a little bit stronger case for treatment in some cases. But in general, if you have someone like a rheumatoid arthritis patient who's getting methotrexate, again, it's probably secondary, but even if they do have significant infections, we may opt to do immunoglobulin therapy for them. All right. Let's see. So, question here: topiramate, is it the dose or the duration or both? It's the bigger problem. It's probably the duration that is the bigger one. So it does seem to kind of suppress plasma cells, which are the actual cells that make antibodies. And so those cells tend to kind of have a long lifespan, and they kind of die out over time. And that kind of seems to be hastened with anticonvulsants. So it seems to be duration a little bit more. There might be some dose effect as well too, though. So I think if you do see patients on Topamax or on carbamazepine or something else that are having infections, it would be a good idea to screen them just to make sure. So a question here: have you seen HIV or AIDS unmask immune deficiency? Yes, it's potential. There have been some reports of people with CVID and HIV, and it's not clear exactly how much unmasking there may be, because they may have different features. So in some cases, you know, the HIV can produce recurrent sinopulmonary infections depending on how low their T cells are, but we don't tend to see the same, HHV8 positive sarcomas and things like that with CVID. So different features, but they certainly can be seen in the same person, and it may in some cases bring the other immune deficiency, the CVID, to light if they get evaluated for their HIV. Let's see. So chronic diarrhea with failure to suppress HIV on correct ART. So yeah, I think probably more telling is if you have chronic diarrhea, but you did suppress HIV with ART. So I think if you've got really good control of your HIV, but you're still seeing things like diarrhea, you're still seeing infections, that's a good case. And I do have a couple of patients. One patient in particular comes to mind who had kind of a history kind of similar to this, where he had HIV, ended up getting lymphoma, treated for lymphoma, was doing well for a while, and then started getting infection after infection after infection. And as it turned out, yeah, his HIV was still very well controlled, but he did have kind of a presentation now where it looks like he does have CVID, and we're treating that, and he's done better since we've started treating him that way. So, all righty. I think that was the end of the presentation. So thank you all very much. And if there's any questions, feel free to always reach out, send an email, Paige, or otherwise just give us a call.
Thank you. That was incredible. And you can see from the number of questions you had asked that you got everybody's interest, and lots of really great questions, and you had the answer to them all. Thank you.
Great. All right. Take care, everybody.
Thanks, Brant.